Welcome to today's webinar, everyone. We're here for Confronting the Opioid Crisis during the pandemic and beyond. I'm Lisa Silverman. I'm your facilitator for today. I'm joined by Dr. Shawn Griffin. Shawn, wanna raise your hand?
Hello, everybody.
I'm joined by my colleague Jennifer Richards with URAC.
Everybody.
And Sylvia Sacalis with Healthesystems. So we're here today to talk to you, show you a little bit about the data that we have on opioids, what's happening, talk to you a little bit through some of what's been happening with the opioid crisis. We're going to cover workers' comp and opioid trends. We're going to cover COVID and mental health and what does that mean for the opioid crisis. And then we're going to move into what can we actually be doing. We're going to go through some of the best practices that we found between the two organizations to tackle opioid use. With that, Shawn, I'm going to turn the floor over to you. For those, many of the group here knows URAC. They know us, and thankfully, I think that means they like us a lot. But for those couple of people on here who aren't familiar with URAC, I'm going to ask you to give a little bit about what we do and who we are.
Absolutely, Lisa. So I'm Dr. Shawn Griffin. I'm the president and CEO at URAC. URAC as an organization goes back to 1990. We were originally founded as being that intersection between around utilization review for the payers, the providers, and the patients to sort of come together and set standards. Over that time, over the past 31 years, we have expanded to where we have almost 40 different accreditations. We are not for profit. We are independent. We see our role as validating quality across the healthcare landscape. I always describe it as regulation often sets the bar for safety, but accreditation sets the mark for quality. We are thrilled that we work with so many organizations, do a lot of work in pharmacy. I'm the first physician to be in this role, and we have a very talented team here in Washington, D.C. I usually get to say it's a beautiful day in downtown D.C., but it's a rainy day in downtown D.C. for this webinar. But we're just here, and we're looking to improve the care of people all around the country, around the world, with our standards and the work that we do.
Thanks, Shawn. Sylvia, I'd love to turn it over to you to just give us a quick overview of Healthesystems, what you do, who you are.
I appreciate it. Thanks very much, Lisa. It's a pleasure to be here with all of you this afternoon. My name is Sylvia Sacalis. I am Vice President of Clinical Services at Healthesystems. In my role, I provide clinical leadership and strategic direction for clinical initiatives. I have 16 years of healthcare experience and clinical expertise spanning technology, group health, and managed care environments ranging from Medicare, Medicaid, and most recently into workers' compensation. I have been practicing in workers' compensation for the past 7.5 years. And just a little brief overview about Healthesystems. Healthesystems is a national managed care services company that's focused on providing healthcare management solutions to the workers' compensation industry. Specifically, we provide a clinically and technologically driven pharmacy benefit management program, as well as a comprehensive solution for managing all the various ancillary medical services that are often involved in treating an injured worker.
Thank you, Sylvia. We want to set up the scene a little bit before we get started, before we have a conversation. We want to use some data to show you where is the opioid crisis today. With that, I'm going to turn the floor over to my colleague, Jennifer Richards.
Hi, everybody, and welcome. So we did want to talk a little bit about what the numbers say in opioid stewardship. So we have a lot of data in this area, and there's a lot of data out there. We tried to pick out some things that really demonstrated and talked to the impact of opioid stewardship. So we're going to start out with opioid usage. So right now, as of 2019, more than 2 million Americans suffer from an opioid addiction, with 95 million people using prescription painkillers within the past year, between 2018 and 2019. Drug overdoses are the leading cause of death for Americans under 50 years of age, with 142 Americans dying every day from opioid overdose. That's a lot of opioid usage and a lot of deaths. So going further into the opioid death numbers, Opioids, there was one slide in between. Opioids are now more commonly used than tobacco. That's a pretty big number. Think of all of the people that you know that use opioid or that use tobacco in some form or fashion, and know that more people are using opioids today. Moving into opioid deaths. In America, more than 72,000 people died from drug overdoses in 2017 alone, and more than 67% of those deaths were related to opioid use. Fentanyl has emerged as the most deadliest opioid drug in the United States, and there were more than 18,000 deaths from fentanyl overdoses in 2016. Drug overdoses are now the leading cause of death in Americans. So we said 142 Americans dying every day from opioid overuse. Now, all of this does relate to cost. Obviously, in healthcare, that's something that we are very concerned about and something that we consider between opioid use and opioid deaths. Our costs are actually pretty high in America. So going into opioid-related costs, we can see there's a $55.6 billion is the estimated cost of opioids in lost economic productivity. And that was from 2016. Between 2001 and 2017, there was $1 trillion estimated as the total opioid-related costs in America. And then also there, between 2017 and 2020, $500 billion was the projected future opioid-related costs. This was from a study done in 2018. So we're talking a lot of money here in America. As we can see, there's a lot of information that indicates opioid use is still a problem in healthcare. We went through opioid usage, opioid deaths. We see a huge cost associated with opioid usage. The numbers presented so far give us a broad overview of what is happening in America with opioid usage as an overall healthcare industry number. To continue this discussion and really look at some of these numbers in further detail, I'm going to pass it over to Sylvia, who will present numbers that are a little more associated and directed with the workers' comp industry and PBM specifically. So Sylvia, I'll pass it to you.
And Jen, before you do that, I just want to remind the audience, we love having your participation during the webinar. We never want you to wait until the end of a webinar to get your question in. And I and some of my colleagues will chat in questions to get your reactions here. So Tina, thank you for being the first person to ask about, was it worse in 2020? Due to the pandemic, because we're about to cover that later on today. But please, look at the questions. We want to hear your reactions. What is this making you think of? What worries you? What actions are you taking? What's good about these numbers? Is there anything good? So chat in your thoughts to us. Sylvia, the floor is yours.
All right, I appreciate it. Thank you, Lisa and Jen. So since we have a broader audience on the call today, what I thought I'd do is take a little bit of time to outline the nuances of workers' compensation and how they differ to broader healthcare, Medicare, Medicaid, commercial. So workers' compensation is a very unique segment of the healthcare population, specifically dealing with people that become injured on the job. And it's typically associated with treating pain resulting from an injury. Most of the injuries that we see in workers' compensation are musculoskeletal, and these might include things like back injuries, sprains, etc. But the commonality for all the injuries is that pain management is often a large component of treating those injured workers. And therefore, opioid prescribing has historically been a significant challenge for the workers' comp industry. A couple more things to orient you in terms of how workers' compensation works. Patients in workers' compensation are not limited to what kinds of services they're able to receive, so long as they're deemed medically necessary and related to the injury. There are often no deductibles and no copays or cost sharing, unless it's a generic mandate state where the injured worker actually wants the brand instead of the generic. And there's 13 states across the country that do allow for the pharmacy to charge the injured worker that copay differential. So the way I look at workers' compensation is really similar to Medicaid in a lot of ways. And it's obviously the copay structure is similar because there's such limited copays associated with these two healthcare segments. And then from a trend driver perspective and regulatory standpoint, workers' compensation functions very similar to Medicaid because workers' comp insurance is required in all states, but every state work comp regulations are highly unique and specific. And so the way they treat and recommend guidelines, how to treat and appropriately use opioids specifically varies across the board. So the key in workers' compensation has been vigilance and a really rigorous approach, because this is the fundamental core aspect of what we do from a pharmacy management standpoint. All the other key aspect is early intervention. And I think this probably applies across the board. It isn't just specific to workers' compensation, but the earlier you intervene, the less likely for a particular case to really, in essence, get out of whack. So a holistic approach is really required in workers' compensation, taking into consideration the various factors that I just outlined. If you want to move to the next slide, Lisa. All right, so workers' compensation opioid utilization. In workers' comp, as I shared with you, it's traditionally been very high. However, we've seen significant strides made in workers' compensation over the past decade. According to a trusted work comp resource called the National Council on Compensation Insurance, we've seen double-digit declines in claims that have opioids associated with them, starting out with 55% of claims in 2012, including an opioid, compared with 33% of these claims at the start of 2020. We did see a very temporary 1% increase that occurred at the start of COVID as the number of claims with opioids rose to 34% in Q2. However, NCCI reporting does not extend through the end of the year. We did take a look at our book of business data, and what we're seeing is that beyond Q2 of 2020, at the height of the pandemic, trends actually leveled off later in the year in Q3 and Q4 to pre-pandemic levels, which is extremely reassuring. We also saw similar patterns in MME trends. So that's very consistent. And we believe a lot of this is because at the onset of the pandemic, healthcare providers were trying to mitigate COVID-19 disruptions. However, very interestingly, based on this analysis over the past year, it would really seem providers had worked hard to ensure that patients who legitimately needed those opioids still received them throughout the pandemic. But overall, the pandemic did not increase opioid prescribing, which was a very favorable trend that we saw. In conclusion to this, while there's definitely various drivers that overall impacted this downward trend, and we'll get to some of those later in the discussion that Shawn and I have, really the point I want you to walk away with is that while we see a reduction in opioid usage, it doesn't reduce the complex nature of managing injuries and improving functional restorations for our unique injured worker population. Next slide. All right, so now let's take a look at some of the important considerations that have been amplified as a result of COVID-19. So no surprise, mental health factors are one of the top areas that have seen an impact due to COVID-19. And in our line of work, addressing mental health issues such as co-depression and treating early on in an injury is crucial in the treatment process. Mental health factors in work comp can really inhibit recovery and functional restoration. And we have received multiple reports from our own patients that engage in our telemedicine program of anxiety due to COVID and isolation. So again, no surprise there. Moving on to social determinants of health. COVID-19, again, had significant economic and social impacts that really exacerbated social determinants of health. Things around education, income level, ethnicity, and household density. These are obviously very important. I think we all know as a healthcare industry holistically that social determinants of health have a direct correlation to adverse health outcomes. And what I want to emphasize here is that we have such a great representation of various stakeholders in the healthcare ecosystem, and we each play our own individualized role in helping these individuals that have challenges with access to health, with access to appropriate social services, and navigating healthcare overall. At the patient level, one thing that we've uncovered is asking patients about some of these social challenges that they're experiencing in a sensitive and empathetic way is crucial, because there's studies out there that directly tie empathy and patients' ability to feel cared for. And that has direct correlations and ties to more accurate diagnoses, better care overall, and improved recovery. So let's keep in mind that wherever we practice, we have the ability to be advocates for our injured workers and our patients overall. The other couple of items I wanted to focus on today as it relates to some of these challenges is access to care. And I think we've all seen that. Ensuring fair access to care is absolutely crucial. COVID-19 definitely shared a big spotlight on that. COVID delayed and inhibited access to in-person care that resulted in a lot of missed appointments for our patient population around physical therapy and different allied support appointments. We received reports from our injured workers that they had to postpone injuries. They had delays in spinal cord stimulator adjustments, which resulted in increased pain for several additional months. They experienced a lack of access to epidural steroid injections. And all of these really stem from the fact that these particular patients were unable to be seen, and these particular types of treatments could not be administered virtually. And so that's a key call out for access to care. Something else that was interesting, in addition to our own data and comp specific, IQVIA, which is represents across all lines of healthcare insurance, reported a very negative and kind of scary trend around medication-assisted treatment. Medication-assisted treatment for opioid use disorder was significantly disrupted in 2020 due to the pandemic. They reported a 22% drop in new patients receiving medication-assisted treatment. While these numbers rebounded slightly in June and July into Q3, they did also see it faltering again in September and October. So this is still an area of opportunity for us holistically as a healthcare ecosystem. I will say, on a positive note, the way that healthcare responded in terms of being open-minded and providing increased access to virtual care was astounding, and it did meet a lot of needs for our patient populations. But let's keep in mind that we need to continue to uncover the most effective strategies, because virtual care may not address all of a patient's challenges. Lastly, another consideration that we saw that was significantly impacted by COVID-19 were changing trends in legislation in response to ensuring that patients had appropriate and adequate access to the treatments that they needed. So many federal and state regulators really amended policies regarding prescription drug treatment. And mostly that was to loosen and allow for practices, including 90-day refills instead of 30-day refills, except for controlled substances, allowing early refills, including for controlled substances, renewal of prescriptions without even seeing patients, and allowing controlled substances to be prescribed via telehealth visit, just to name a few. And so I would say in workers' compensation at a Healthysystems specifically, We were really responsive in implementing these new regulations because we did want to support our injured worker patient population to ensure they had access to needed treatment during the pandemic. Next slide. So now let's talk about monitoring and intervention strategies. What are the keys to meeting some of these challenges that were presented by COVID-19, and how did we respond? And this is really more from our pharmacy benefit management perspective. So the first line of defense that we deployed was our formulary management strategy. And we did so in a very agile and responsive fashion to ensure that all of the appropriate guardrails were removed and to promote that early access. And the formulary, what it does for the broader audience that's on this call, it really does allow us to have appropriate oversight and to minimize unnecessary risk, while ensuring that our patients still can receive the appropriate medications that they need. But formulary management is just one tool, as you'll see in the next couple of items I will cover, which is really a multi-pronged approach that's required to have a synergistic impact. Moving on to prescriber monitoring and analytics. We really do work hard to deploy and utilize technology to support monitoring and to drive appropriate interventions at the right time. And we do know that from a clinical standpoint, early decisions are especially crucial to ensure we get those patients on the right track. As a clinician, the most important step from my perspective to avoid claim escalation is the ability to be able to recognize and flag those patients and providers that pose the high risks. And we do that by leveraging our clinical expertise as well as our technology and analytics. And this is an evolutionary work in progress. One thing that we are working on this year that we think is going to provide much incremental value is going to be incorporating natural language processing into our analytics to help better understand and organize unstructured data. A lot of the information in medical records is unstructured, and sometimes it's not leveraged effectively because it's not able to be collectively implemented into our analytics tools. And so we have a huge focus on that area, and that's also going to drive the appropriate access to unstructured data elements like comorbidities and psychosocial pressures that really do affect opioid and the opioid epidemic overall. A couple of other things to focus on. So analytics really drives identification of risk factors, and it helps us to know when to timely outreach and target and provide interventions that are closely tied to risk factors. A couple of different types of outreach programs that we offer. One is geared towards prescribers because obviously they drive the prescribing of treatments for our injured worker population, as well as the injured worker patient outreach program. We really believe that working with prescribers and honing in on weaning support and educating them on the importance of having an exit plan at opioid management is absolutely crucial to getting those injured workers to get back to improving their functional restoration. And lastly, but very significantly, because we do believe that the injured worker is at the center of their own care and we want to empower them with the COVID regulations that were relaxed as far as telemedicine, we started incorporating the actual utilization of video in our telephonic outreach program to better promote higher engagement with our injured worker population. So thank you. That's all I have.
Sylvia, thank you very much. I just wanted to ask you some questions. I think that when we think about this, you know, I trained decades ago now, unfortunately, I have to say, as a provider. And back when I trained, you know, we were in the opioids are bad sort of swing of the pendulum. And then it became, you know, pain is the fifth vital sign and opioids are okay now. There's new opioids and it's the new and improved opioids and people use them more. And now we're sort of swinging back to opioids bad and a lot of press around those ways. When you think about opioids, what were you seeing before the pandemic started? Just what was the usage? What was the view? How did you think opioids were being used at that time? And sorry about the siren behind me if you can hear that.
We can't hear it, and so no worries at all. Okay, prior to the pandemic, actually in workers' compensation, we saw a significant positive improvement, double-digit declines in opioid prescribing and utilization over nearly the last decade. So I think you recall one of my last slides addressed the NCCI reporting of that declining. Unfortunately, because NCCI really went only up to Q2, and we looked at our book of business data, we actually saw all of that reverting back to baseline, which is obviously super encouraging because the reductions in opioid prescribing were still being supported. So that was a positive. We also saw a remarkable improvement in first-time use of opioids. There's been a lot of efforts across multiple states and focusing on reductions in quantities as well as durations of therapy associated with opioids. So workers' compensation regulators have really helped to battle through state prescribing limits and put in some of these guardrails to help support that. Also on a positive note, because we saw the declines in opioid prescribing, we saw a positive shift to non-opioid prescribing for pain management with drug categories like the nonsteroidal anti-inflammatories, things like ibuprofen and dermatologicals. And so that was one other positive trend. And lastly, looking at our own book of business since 2016, we've seen a decrease in co-prescribing of opioids and benzos, which are a dangerous cocktail and really can be pretty deadly.
Yeah. So when it comes to, workers' comp is its own bit of field. When you think about the opioid management for people in workers' comp care, how do you see the management of those? Who does the ball fall to sort of keep an eye on those things? Is it multiple people? Is there a conversation that happens between the work comp provider, the clinician, and insurance company? How do you see that happening?
Yeah, so that's a great question. So the way we look at it is the responsibility is really a shared responsibility. There's not one key stakeholder in that process that's going to be able to affect change on their own. And so the shared responsibility is really a result of collective results and collective work that's been done at the federal level, new guidelines, new guardrails, but specific to comp, we've had a significant work comp industry focus on driving the state level regulations and changes to further support the federal guidelines to ensure that we're driving a heavy focus to mitigate opioid use, or at least to help with the decline. So it's really a collective effort, federal level, state level, and it's also a collective contribution from our workers' compensation partners. And that ecosystem consists of the providers, it consists of the employers, it consists of PBMs. So it's really coming together and figuring it out as a healthcare team to ensure that we have the right approach to continue to sustain these positive efforts.
Yeah, you talked before about the co-prescribing of benzodiazepines and opioids and the danger that can be in that combination. We've seen during the pandemic the increased mental health stress, the anxiety, the depression. We've seen stories and talking about all of those things. When you think about that, what is your view? Are you seeing other effects of this that are coming into what you're seeing come across your desk?
Yeah, so as it relates to psychosocial pressures, we've seen pronounced psychosocial pressures. I think we're not alone. Workers' compensation is definitely not alone. And one thing that's really benefited us is close communication with our stakeholders as we're identifying a lot of these. Through our patient outreach program, we've really been able to actively, through empathy and support, uncover a lot of different very pertinent concerns. I think for some reason, because pharmacists really are a trusted healthcare resource, patients feel comfortable opening up and sharing some of their challenges. We did see an increase in antidepressant and anxiety medication use, but it was very minuscule. It was literally a couple of percent based on our book of business. So the one nuance I want to draw attention to in work comp, though, is when you see an increase in antidepressant prescribing, some antidepressants are actually used to treat neuropathic and musculoskeletal pain. So it's important to be able to marry the data of the actual drug type with other data points to ensure that we're not seeing a false increase in depression, which could actually be an increase in chronic pain treatment.
Yeah, you talk. Oh, actually, let me try this, Lisa, before you give me my next path. You talk about seeing the changes in prescribing percentages and those sort of things.
Mhm.
At the beginning of the pandemic, we also saw a huge change in employment. We saw a lot more unemployment go up, and people were, if people look at this data and they say, well, we're seeing a decrease in opioid prescriptions through work comp, is it that we're just seeing a decrease in work, and so therefore we're seeing a decrease in work comp claims?
So yeah, I mean, I think there's definitely some correlations. So according to the NCCI, which is our work comp trusted resource on industry data, the overall number of work comp claims dropped by 26% of Q2 of 2020. And obviously that's a result of various factors, right? So it included reduced exposure. Many organizations were able to shift to remote workforces, as well as potential delays in reporting injuries. However, these reductions really reflect an average across our industry. We do recognize that there are certain industries who unfortunately we're not able to go into a remote force environment. And so we're waiting on Q3 and Q4 industry data so we can better understand what vulnerable populations were more significantly impacted by COVID-19. So again, just to reemphasize, as I mentioned earlier, the proportion of opioid claims really did remain consistent, but I'm sure there's going to be some correlations as we get more data through the end of the year from an industry perspective.
Yeah, a lot of the organizations that we work with have been doing their own sort of opioid work, and that's actually where this opioid stewardship designation came from, is because we were seeing organizations that were doing this and they were having their own efforts, and this was before COVID. And we said, how do we highlight organizations that are focused on this? Because it's one thing to do the work because it's good to do the work. It's another thing to do the work because somebody says it's a good thing to do and they're doing it the right way. Our opioid stewardship designation, which we'll talk about in a little bit, was one of our efforts. When you think about what you were doing for opioids and drawing a light to that, what were some of the things that your organization in particular was doing? Anything that you want to highlight for your programs?
Yeah, there's a couple of things I want to highlight. So I know I spent a little bit of time in the presentation providing an overview of various strategies. The two key strategies that I want to hone on a little bit deeper in terms of what's really been working and what is kind of a differentiator in the industry is our focus on our analytics. Analytics has and continues to be our backbone. It drives early identification of risk, and it drives effective decision making because we can put the right information at the right time in front of the key stakeholders. And so our analytics, coupled with our engagement programs, that engagement to both providers as well as to patients, those are the most effective strategies that we've seen. Because we're able to deploy an empathetic approach. We really focus on education as part of the empowerment to the patient and the provider population. And so we see those strategies being the most successful because a lot of times the injured worker is the forgotten, for whatever reason, the injured worker patient is the forgotten entity. And we believe it should be the center of everything that we all as healthcare stakeholders do. So those strategies, in our opinion, have been the most successful at driving profound change.
And I want to thank you for coming on and for doing this with us and for sharing your experiences. I do want to turn it over to Jen from our team to talk about what we're doing with the opioid designation. I'll just say to the people who are in attendance, we love highlighting the great work that organizations that we work with are doing. And if you have something that you're working on, reach out to our marketing team and let us know, because we'd love to highlight how you're helping to take better care of people. But I'll turn it over to Jen to talk a little bit about our stewardship designation.
Thank you, Shawn. So our opioid stewardship designation is a new designation that was released earlier this year. It is a designation recognition, so not a full accreditation or certification. Lisa, can we go to the next slide? So when we started out creating this recognition program, our goal was really to create something that allowed organizations to be recognized for promoting patient appropriate access and use of opioid medications. So this program is really designed to allow organizations flexibility in what the program itself looks like, while utilizing a framework of designing and implementing a strategy, intervention, and/or treatment, and then requiring measurement over time, initial measurement, remeasurement. So in the end, we were looking to really provide organizations the support to demonstrate what they were doing really well. Next slide. So as you know, we have many, many programs here at URAC. And this designation really does fit well with many of our programs. It does have to be an accreditation or certification, and the organization needs to either directly work with patients who utilize opioids or impact opioid usage in some other manner. So pharmacy is obviously the primary space where we would automatically look to add this designation on, mostly because they really manage the opioid medication directly in some manner. This is a pretty easy area to look at opioids and how they're being used within the pharmacy space. In addition, we did have health plans and dental plans, case management, and utilization management. All of those organizations deal with consumers who may utilize opioids, whether they're directly touching the patient or helping employers manage the opioid use. Some of our newer programs in the digital health suite would also work well with this designation. Telehealth being the foremost. This is a new program for us. And this is a program, this is a newer revision of a program for us. And we see that a lot of organizations are now, or a lot of patients are now turning to telehealth as their primary mode of care. And using the framework of telehealth plus the framework of the opioid stewardship designation can really help those patients manage and really appropriately use their medications. And then lastly, we also have some administrative programs that really may be able to impact patient opioid use, looking at the clinically integrated network, our patient-centered medical home, and population health programs.
Jen, somebody asked if the program can sit on top of drug therapy management. Where does this?
Yes, yeah. So, drug therapy management organizations are, again, in a really good position to help patients manage their medication use overall, and opioids is a part of that. So yeah, this program would definitely sit on top of that. In addition, if you're not seeing your program listed here, and we have 43 programs, so we couldn't fit them all on one slide. If you're not seeing your accreditation or certification listed here and you're still questioning whether or not this designation would fit on top of it, definitely reach out to client relations managers or business development executive just to see if this would be right for you. It sits on top of almost any program. So there's a high chance that even though it's not listed here, it's something that would really work well for you.
Jen, I think that's one of the selling points of this program is that, yes, we've narrowed it down to about 10 programs here that we know it sits directly on, but there's so much more here that it could sit on. So if you are one of our clients and you are doing work in the opioid sphere, anything in the prevention, treatment, we want you to be in touch with either your client relations manager or the business development executive with whom you're working, or through our website. Let's chat about it because we think this is flexible enough. And Jen, you're going to talk about the flexibility of the program in the next slide, but we think it's flexible enough to really work with what work you're doing. The most important part we say is better patient care. That's what we're still always aiming for here.
That is what we're going for, yes. As you can see here, this is an outline of the standards that are included within the designation. It's very simple, 4 standards total within 2 focus areas, and there are EP or elements of performance groups within each, but really a very simple layout here. So the first focus area lays out the framework for developing the program, looking at, making sure it's evidence-based and what is the scope and what is the objective and what are you going to do? And then moving into the second focus area, really laying out the framework for administering the program and evaluating the effectiveness of the program. Is the program really working? The goal, again, was to create a program. The goal is to create a program with strategies and interventions and then measure how you're doing. We didn't outline strategies, interventions, and/or treatments that are specific. We left it open on purpose. We want you to be innovative and we want you to really figure out what is going to make an impact for you and your patients.
There's one question I just want to address. When we do these things, these designations, if you've been through a URAC accreditation, you know that we check all tons of stuff in a full accreditation. A designation is a much lighter sort of cherry on top for somebody who's already gone through, full evaluation with URAC. And when we make it that simple and that straightforward, we also try and make the price that simple and straightforward. The list price on this is $5,000, which is one of the lower costs of all accreditations and those sort of things out there. And we really mean this as a reward. This program is meant as a reward for organizations that are working on this way to improve care, and it's meant to be flexible enough to work with a lot of different organizations. I would love for a lot of organizations to get the highlights that they deserve for doing this kind of work and improving care.
Thanks, Shawn. Thanks, Jen. I want to make sure that we allow time for questions from you. We've got our salespeople on. Shawn just answered that big question about the cost. Jeff chatted it in. Shawn, I'm going to throw a question out here at you, and you can field it to Jen, and Jen can answer it as well. But I always like to ask you these kinds of questions because you get excited about things. What excites you about this designation as a physician, as somebody who's been practicing, as somebody who's been in the hospital system? What excites you about this?
Well, I mean, years ago, I did work comp. I mean, I was workers' comp doc for our hospital system. I would see people with the sprains and strains and those sort of things. And there's really sort of an opportunity to improve their care. I mean, you're taking somebody who's basically in a bad spot. They're not doing well. They're worried about their job, all these sort of things. And to work with an organization to say, how are we going to take care of these people better? And maybe not do the simple thing, which is to write a prescription and to send them off and not worry about, but to actually partner with them. And I think that our opioid stewardship designation is really an example of highlighting those organizations that are partnering with patients to provide them better care. And yet it's flexible enough to say how this looks within your organization is different. And it's not going to be a cookie cutter. Nobody in medicine likes to be told, you have to dot the I and cross the T and wash your hands twice and do the hokey pokey. But we want to say, if you're workers' comp, this can be what your program looks like. If you're a provider group, this can be what your program looks like. If you're a pharmacy back in a hometown of mine in Iowa, you could qualify for this. And we think that opioids have been such a danger and such a threat in their overuse and the social impact that we've seen, that if we can put something out there that helps to change behavior for organizations to improve care for people, we think that's a great win for us.
Awesome. Thank you, Shawn. Jen, I'm going to ask you the same question. Jen, you were one of the big driving forces behind this on our program development team. Jen, for perspective, you're coming at this from both a pharmaceutical and a legal perspective, and this touches both. What excites you about this? It's launched. Hopefully you're sleeping a little bit more. What excites you?
Yeah, I mean, this program, when I first came into product development with URAC, I think this program was a much broader program, and it tried to narrow scope a little bit more than what would really drive innovation. So my goal with this program, and one of the things that I love about it, is that it is so flexible that an organization who really wants to highlight what they're doing can do it. Easy enough. This program will give you the structure and the framework to document all of that and to make sure that you have really good processes for measuring and all of that. But if you're already doing something in opioid stewardship to really impact your patient care, then this designation should work for you. And that was the goal. I wanted to give organizations an opportunity to really show what is working in opioid stewardship so that other organizations can tie on and add on and really work to decrease the opioid crisis overall.
Jen and Shawn, you both know I come out of a public health perspective. And I remember a couple of years ago, before COVID hit, being on Capitol Hill, and health department directors from local counties were saying to me, I can't talk about teen pregnancy right now. That's a minor problem. I got to stop my people from dying. So hopefully this stops those community members from dying so that health organizations can really focus more on the prevention. Hopefully this is a step in that right direction. So I'm always especially proud of the work we're doing because I know that it's going to hit at the community level. Timeline for, Jen, I asked you this and I'm going to ask you to share it publicly. Let's talk timelines with us. Everyone wants to know, how do I get through it? How long is it going to take?
Sure, yeah. So if you're adding this onto if you're already going through the process of accreditation or certification, and this is a add-on program to that process of seeking accreditation or certification, the timeline is going to be the same as the main program under which you're seeking. If you are adding this on in between cycles, so you've already achieved your accreditation or certification, you're in a full status, and you would like to add this designation on after the fact, your timeline is going to be shortened. At this point, we're looking at a 6-month total turnaround time for these programs that may be shortened based on how quick and easy you get your documentation together, how ready you are, the reviewers being able to view and do the validation review within a certain amount of time. 6-month total time frame means from the time you sign the contract to the time your determination comes through.
Yeah, and I just want to emphasize something. This is not simply a you submit your money and we send you your certificate. We actually will. If you've ever worked with URAC, we actually check stuff. We ask for the documentation, we ask for the information, we ask to see your meeting minutes and those sort of things. So I mean, this is a real. We will check your program, but we're not going to spend 2 years asking you to do poster sessions at the national meeting or anything like that. So we're trying to do everything faster. We're trying to do everything more timely. We want to get this so that people see it and they understand that you are making a difference in your community with the people that you care for.
We've had some great speakers here today. I want to ask each of you, Jen, Sylvia, and Shawn, what's your big takeaway right now with the opioid designation? The middle of COVID, we're a year into it. I know in my county, 25% of people have received their first shot. So we're moving forward, but as you can see, many of us are still working from home. Opioid crisis hasn't gone away. It's still there on the streets of downtown DC. You go downtown DC, you go downtown Tampa, downtown Phoenix, wherever you are. What's your takeaway? What's still on your mind as we kind of go into the next, whatever this next post-COVID era is, and opioid stewardship? Jen, I'm going to ask you to start, and then Sylvia, and then Shawn, and I'll ask you to just close us out at that point.
Sure, yeah. So, I mean, for me, it's we can always do better, right? So, as much as we're moving forward, and a lot of Sylvia's numbers were great in showing that we can decrease opioid use and make sure that the opioid use is appropriate, we can still do better. And hopefully this program and what we're outlining here is, and as well as, just looking at what you're doing in your own healthcare system and industry and where you're at practicing, you can make changes, and you can create interventions and strategies to keep moving forward with this. And hopefully eventually we will get to a point where this is not a crisis and we don't get to call it that anymore.
Mm-hmm.
I can go next. So thanks. I do support everything you just said, Jen. I think it's a work in progress. We have made significant strides. There's still strides to absolutely be made. I think it takes vigilance, ongoing vigilance. I think it takes collaboration and partnership, recognizing that each entity that we partner with brings their own level of expertise, and together we are stronger because there is not a one size fits all approach, as we all know, right? So helping one another, learning from each other, partnering together to be able to, holistically tackle this, I think is going to be the key to sustained future success. And lastly, something a little bit unique. I always try to throw in the humanistic aspect. I think empathy is crucial. I would highly challenge each and every person to remember that, yes, there are people who are abusing the system. That is not a surprise to anybody in any line of insurance. But there are also people who genuinely want to get better. And so let's be empathetic. Let's listen. Let's be caring. And then let's work together to take into consideration individualized patient factors to ensure we're really making a difference holistically.
Thank you, Sylvia. The thing I'd say, first of all, Sylvia, thank you so much for coming on with us and for sharing your experiences and your statistics and your viewpoint. As we talk about this, Jen, thank you for the great work at putting this together, and to the whole team at URAC. Thank you, Lisa, for putting up with me on a regular basis as we do these webinars. For me, the takeaway is that we had this idea years ago before COVID hit about how we could be improving care, and we created this designation. It's reflective of some change that we've had at URAC, trying to focus on things where we can highlight excellence and we can highlight innovation in a new way with a lighter format and those sort of things. 93 people got on this webinar when we were doing it live, and they heard these experiences and those things. But as we do this is all about the fact that as our number one core value at URAC is we value people, and the people who are going through this, or who are seeing family members go through this, they need our help. They deserve our help. They are valuable people, and this designation is just another sign of how we believe that when we all come together and we work on the needs of the people, that we're making some good in this world. And I think that right now we can see some light at the end of the tunnel, and it appears that people are getting vaccinated, and the world's going to get back to precedented times as opposed to the year we've spent in unprecedented times, as all the commercials say. So I just think we want to highlight the good people, the good work, the good difference that got a lot of us into healthcare, because we went in there to take care of people. And this is just another way that we can help take better care of people and share our experiences and share best practices in a way that can make a difference for our communities. So I thank all of you for being on here with us today, and for asking the questions, and Sylvia for getting on here with us. So just thank you all for this time that you shared with us today.
Thanks, everyone. This concludes our webinar.